Hello, welcome everyone to our presentation on our virtual series on collaborative care. And we're hoping that you will feel more confident at the end of these presentations to engage and embark on collaborative care models for your own practices. So you will see that section 5, our section, is on establishing value and securing funding for your work. And we have a panel of 4 child and adolescent psychiatrists and academy members. And one of us is a physician assistant at a practice in Delaware, and she will be presenting as well from the perspective of a behavioral health care manager. After you take time to review this section that we are pre-recording for you, we'll be scheduling question and answer session with our 4 panelists at some future date so that you'll get to ask questions and get answers additional to those that you might hear about today. Our goal is to inspire you to consider one or more of the collaborative care models as a portion of your practice, to enhance and expand child psychiatrists' reach in evaluating and treating youth and families. We present 4 perspectives, including how to bill and get paid in a small practice as well as in a large program. These are but a few examples, but much can be generalized to the many other collaborative programs and pockets of collaborative care emerging across the country. There are a number of resources which give more detail on setting up each model, and I just want to mention those very quickly. For a collaborative care model, the University of Washington Ames Center, APA, AMA, AAP, and the Meadows Mental Health Policy Institute have all been contributors to our knowledge and more detail on collaborative care. Also, the MCPAP program, MCPAP, and the National Network of Child Psychiatry Access Programs is available for additional information on the child psychiatry access programs. So whatever your current practice, we hope you're encouraged to pursue a collaborative model as an enhancement of your practice and for which you can get paid. I'm presenting first, and then I wanted to show some slides that relate to payment for various models. My name is Mark Bohr. I'm a child and adolescent psychiatrist in Dover, Delaware in private practice. And I also work with the Academy in a number of roles that you see up there. And I'm proud to say that I'm also working with our Child Psychiatry Access Program in Delaware, as well as our collaborative care model at Delaware Pediatrics. Right now, collaborative care codes are covered by most commercial insurers and many of the Medicaids in the country. And we see this coverage of codes as a win-win-win for kids, for us as child psychiatrists, and for the payers. Youth and families get to care sooner, especially kids coming out of hospitals that might be on long waiting lists, or kids who have been through crisis or an emergency department visit who are on a long list for care, or they've been referred by their therapist. We can start to give them care sooner, right through their primary care practice. We team up with the pediatricians and the primary care teams, and we devote part of this practice to working with kids, even when there are few openings for direct care. And insurers, which offer employers and members the collaborative care model, this provides timely access for psychiatry-informed care, and this can increase the ability for insurance panels to say, you know, we have enough members to deliver this care, and we can get you in with your pediatrician right now. It increases our opportunity to team with our other partners in mental health who may be working within primary care practices or in association with them. And it expands sustainable and equitable access to our community supports, which is so important for kids with issues with social determinants. I'm going to show 3 slides just about models that we use, 3 of the models we use. And the first one is just our traditional model of care. Many of us see patients directly, kids, families, and we may send a report, or we may collaborate by phone or by telemedicine with a primary care physician or clinic. We may also be in contact through writing And we may be in contact through any of these methods with an embedded or consulting clinician, a psychologist, social worker, or licensed counselor. And we bill for that using the evaluation and management codes and the add-on psychotherapy codes. And those are reimbursed by most payers and Medicare and Medicaid. For child psychiatry access programs, you'll see that there's less emphasis during that component on the direct evaluation by us of the patient and family, but there's more emphasis on us helping the primary care teams deliver care. And so that's why you see those direct arrows. We also do trainings on issues in mental health, particularly in child psychiatry, including evaluation and medications. And then the programs often provide community outreach coordinators to help bridge out to schools and community services. And this is usually paid for right now. Many are paid for by a HRSA grant through the federal government, but they are working towards sustainability with having a group of payers within a state. It could be insurers and the state agencies working together, or other arrangements to be able to keep this model going even after grants run out. And then this looks like a little bit busier diagram. This is the last diagram I have for you today. What I'd like you to see here is the collaborative care model. And the big difference here, we're still mostly working with the primary care clinicians and their practices, but our main contact, as you'll see, is with the one in green there, the behavioral health care manager, who is someone that has either been hired within the practice or is coming to the practice. And that behavioral health care manager keeps a list of patients that are followed, usually on a weekly basis. And you'll see that bottom line there, as in communication with the child psychiatrist. We review the cases once a week. We try to get through everybody once a month. And that behavioral health care manager, besides talking with us, they're in regular contact with the family. They are doing measurements to note improvement or need for improvement in care. They're in direct contact with the primary care practice. And they also form a connector bridge to therapists and services out in the community. What I want to emphasize here is that you are paid as a consulting psychiatrist in this model. Each patient on that registry list, and you might have 30, 40, 50, 60 patients that you're following over the course of a month, gets billed. A bill is sent for them for one unit per month per patient. So it's a per patient per month billing, and that goes to the primary care practice. And the primary care practice then pays the consulting psychiatrist, usually on an hourly basis, pays the behavioral health care manager, and there's extra funding within that if you are billing a number of patients to help with infrastructure and help support the practice to continue taking new patients to be followed. And I wanted to show that child psychiatry access programs and collaborative care models go together. They go hand in hand, where child psychiatrists and psychiatric nurse practitioners are in short supply. The CPAP, again, with a consortium of payers, expands access so that primary care physicians can contact a child psychiatrist through the program and discuss one of the kids in their practice and better manage those kids within their practice. Once they make enough encounters or referrals on a number of kids, they're more ready then to be able to embark on the sustainable collaborative care program, where they actually have the list of patients and the behavioral health care manager to follow them along with the child psychiatrist. And then as COCM expands to schools, the school registry shows those youth needing further psychiatric diagnosis and prescribing. It doesn't take the place of the things that schools already fund, but it allows then a connection back to the primary care practice and the behavioral health care manager, where services can be delivered and billed under a collaborative care model. Okay. You have some questions for me, Susie.
Yes, Mark, thank you so much for that overview on how effective and sustainable collaborative models can be something that child psychiatrists can embark on in practice. And what I wondered about was, as a child psychiatrist in a small psychiatric practice in a smaller state like Delaware, I wonder if you could give us a little bit of an overview by how you have approached and achieved payment over time for collaborative and integrated care in that setting.
Well, very briefly, we had the fortune of having our child psychiatry access program fund our initial pilot, where I would meet with the primary care practice, Delaware Pediatrics, where we established the behavioral health care manager and the workflow. But very soon, as soon as we started getting patients on our registry, which we developed at that practice, we could start billing insurers for the time we spent, at per patient per month billing. And that way we were able to build a sustainable program. We're a small practice. We're only working one practice at a time. And that Delaware Pediatrics, is going to be part of a bigger consortium, and we may be able to spread some ideas to that and to other practices in Delaware through that means.
And what is the current status of sustainability and scalability for collaborative and integrated programs to which you consult?
They're sustainable right now through collaborative care code submission, but as you can see by this diagram, you're tying in lots of people for the benefit of the patient and family, including community services and agencies. So in the long run, you're already setting the stage for value-based payment, for alternative payment, and for capitated payments. And that will give more scalability.
That's great, Mark. Thank you. And I wondered about your perspective, especially in the setting where you are. What do you think are the most significant challenges that you face expanding access to care in a smaller state?
Well, one would think it's easy because we can get to talk to and know a lot of people or serve on committees, which we do. But our various agencies don't always communicate that effectively with each other. So we're usually the ones that have to do a lot of the legwork to get programs together. We've made trips to our insurance commissioner to help us talk to and help our programs understand better what we're offering. We've worked with our Division of Child Mental Health and our our Department of Public Health on seeing the benefit of these programs and helping us expand them. So the future is promising, but again, we're still one practice at a time. Others, as you will be showing soon, are starting with a bigger program first. Either way, I encourage people to embark on these programs. Thanks, Susie. So now I'm going to get to introduce Susie Nelson. She's going to tell us about herself, and she's going to present on work with a bigger program, which also happens to be a training program.
Thank you, Mark. I'm Susie Nelson, and I currently serve as the director of an integrated behavioral health service through Dayton Children's Hospital in Dayton, Ohio. As you can see, I also have some clinician educator experience and often bring that viewpoint into this work. As we look at the slides today for my portion, I want to let our audience know that we will discuss mostly the big picture overview for the program that I serve. Each slide has several details that are included that may not be in the discussion today, and those details are available to serve as references and resources for you when you want to take a closer look at the roles that will serve on your teams. And Mark, thanks for being here today for this discussion.
Thanks a lot, Susie, and I'm looking forward to your comments because I know you've been working really hard with getting collaborative care established. My first question is, you've been a member of our Healthcare Access and Economics Committee at the Academy and a strong proponent of collaborative care delivery in conjunction with other mental health professionals. Can you speak a bit to the relationship between child psychiatrists and psychologists in building your program as a sign of multidisciplinary collaboration, and can both be paid in collaborative care models?
Yes, interdisciplinary collaboration is really critical to being able to succeed in this work. And as you can see in the diagram, we have our roles represented for the Integrated Behavioral Health Program. And this is with a PCBH, or Primary Care Behavioral Health model, combined with an integrated psychiatry model in the setting of an academic pediatric practice. Taken to an appropriate scale based on the size of the pediatric primary care practice, both a child psychiatrist and pediatric psychologist can be paid using collaborative care models. Our program is co-led by me as the child psychiatrist and my colleague who is a pediatric psychologist. We meet regularly and maintain accountability to each other for fidelity to integrated care models, and we are both responsible for the support of our pediatricians as well as professional development for all of our program's clinicians. Having equal stake in the vision of our program enables mutual trust as we co-lead this critical work.
That's great. And it gives your trainees an opportunity also to see multidisciplinary work. Susie, you've been a Child Psychiatry Fellowship Associate Program Director and now have the privilege of running a general psychiatry training program. Can you tell us how you implemented collaborative and integrated care in your program, both as a service delivery model as well as training for those child psychiatry residents and fellows?
Yes. Absolutely. Our integrated behavioral health program is unique in that it offers multiple levels of collaborative and integrated care within one practice. We offer primary care behavioral health with embedded therapists in our pediatric clinic and integrated child psychiatry. And I take internal referrals in the pediatric practice to utilize as learning cases to return the care to the pediatrician. We are currently beginning a pilot collaborative care model, or COCM, utilizing the patient registry and care manager. And all of these layers of integrated care occur in an academic setting. And as we see toward the bottom of this slide, we have pediatric residents, psychiatry residents, child psychiatry fellows, family practice residents, pediatric psychology postdoc fellows, and psychology doctoral students, along with medical students that all train in the model together.
Thank you. And it's great that you're having ways to deliver care with the support and to give support to the pediatricians, which is going to be so important for our field going forward. I understand there are community pediatric sites that are part of your integrated care program. Not every site will be academic or a part of a larger medical center. How do you plan to achieve multiple layers of integrated and collaborative care when the child psychiatrist is not internal to the pediatric practice?
Yes, and just to kind of remind about the setting for these slides, because I'm aware that they have a lot on them by way of explaining the roles. But what we focus on this slide are simply the relationships among the roles within a program, and those detailed notes are available as a reference for your later use. But as we kind of take that look at this from sort of an overall outlook, this is an alternative to the model that we have in our academic pediatric site, where we have a child psychiatrist within the clinic who can take short-term referrals. What we see here is a future state for our community pediatric practices in the region, but that are distant from the academic site, and that site is closer to a larger medical center. Community practices are served by a co-operational model that includes PCBH with embedded therapists within the pediatric practice, focusing on brief and solution-focused psychotherapeutic interventions. It will also include the COCM, or Collaborative Care Model Informal, where a child psychiatrist does not take as many regular consultation referrals, but serves as the external behavioral health consultant with a care manager to follow patients on a registry, using measurement-based care and with the medication management remaining with the pediatric primary care clinician. And we're going to hear a little bit more about some of the details of that later in this talk. This expands access to psychiatric services since cases can remain in the pediatric practice. And as we hear more about the program in Delaware, it's improving that access later in this session. I want to kind of point out that this is a really critical aspect of advocating for and increasing investment in primary care. Mark, you and I serve as delegates to the Primary Care Collaborative, which advocates for that. And these types of models really help support those aims of investment in primary care and increase of the healthcare dollar for primary care by ensuring that we can keep care in the primary care office as much as possible.
Thanks a lot, Susie. And I know that our pediatric colleagues are also looking forward to models that work for them. And we're showing them models that can work for them, give them support, and help them feel better about their practices as well. How do you currently fund your integrative efforts? And can you talk a little bit about sustainability of your program? Because I know that's going to be one of the important questions we're trying to answer.
It's definitely the question that we're actively answering in our program, on a regular basis here, as is demonstrated in this slide. And you can see through each stage of this funding and sustainability, there is a continual reevaluation for where we are and where we are going. So we are currently funded with a philanthropic behavioral health investment to foster innovative models of mental health service delivery. This allows us a little bit of room, kind of wiggle room, to develop the infrastructure that we need to maintain a consistent integrated model. All clinical encounters here are actually billed, except for our collaborative care model pilot program, as those codes are not currently reimbursed in Ohio. And our COCM pilot data should model reimbursement to scale on the basis of an assumed patient population to predict how to proportionally staff COCM and other pediatric practices. Pediatric population mental health benefits will help us advocate for COCM reimbursement at the state level. Our behavioral health consultants and integrated psychiatrists all work toward meeting all of the same productivity standards that are set by our parent institution, so that when investment is complete, our clinicians will all be financially self-sustaining and can remain with this endeavor. Depending on the model that is most feasible in the community, child psychiatrists can work in this integrated collaborative care space over a range of part-time schedules. There's a really nice level of flexibility to this type of work, and it offers great opportunities for consultation, collaboration with primary care partners, and participation across systems of care.
Thanks, Susie. And I love your inspiration and your passion for this. And thanks for showing us how it can work with big programs as well. That's wonderful. Next, I'll let Tristan Garindo introduce himself and show his slides, and then I'll have a few follow-up interview questions for him.
All right. Well, thank you, Mark. It's a pleasure to be here today. I'm Tristan Garindo. I'm the Chief Medical Officer for Optum Behavioral Care. In this role, I oversee about 300 clinics nationally, including a number of primary care integrations where we are providing collaborative care. I also work closely with Optum Behavioral Health in some of their benefit design and innovation, including how Optum can support the development of programs like collaborative care. I'm going to share with you a couple just high-level remarks representing the general viewpoint of payers. This doesn't represent Optum specifically, but is really meant to represent where payers in general are in terms of integrated behavioral health. If we take a step back and we look at the trend in behavioral health over the last few years, we know that demand for behavioral health services, particularly since the start of COVID, have been increasing year over year. And as a payer, as an insurance company, there are several key things that they're really focused on in terms of trying to address this increase in demand. And they align in many ways with the things that we as clinicians think about when we're trying to manage our own patients and their needs. So the first is really that we want the patient to get to the right level of care. It doesn't make sense for every kid with garden variety ADHD to be routed to the world's expert in ADHD treatment for advanced psychopharmacology. In many cases, that child with ADHD can be taken care of right there in the primary care setting, as we're learning about in collaborative care. We want to make sure that kids are receiving evidence-based care with clear treatment targets. Again, as we've been talking about collaborative care, the use of a registry really supports that type of treatment. And we really want to make sure that even though we talk about the behavioral health and the medical health system as being separate systems, that they're really coordinated in the efforts that are displayed to help take care of kids. And so as a payer, we're looking at how do we make sure we get the right kid to the right treatment at the right time. And we also want to create access. That is such a huge part of what is driving the behavioral health demand, is that as we create more access anywhere in the system, our patients and their demand are right there to meet it. And so we basically have patients in the system in this kind of forward feeding cycle of ever increasing demand and access. So new models that create access for our patients, like collaborative care, that don't necessarily push patients into the traditional behavioral health treatment, are of extreme interest to payers. And as we've talked about, collaborative care really helps advance these goals. So if we step back and think about where are payers, generally speaking, in terms of the collaborative care codes, the good news is that most payers on their commercial plans are paying for collaborative care codes. All the major players are, most of the regional plans are. And so getting paid for collaborative care in commercial plans is not really a barrier. Medicare also pays for collaborative care codes. In some ways, the reason we're having this conversation today is because about 2016, the Center for Medicare and Medicaid Services gave a giant grant to increase awareness and availability of collaborative care services, which has really propelled us to where we are today in terms of being able to have this national conversation. So Medicare is all in on collaborative care. And slowly, state by state, we have seen Medicaid plans come online with collaborative care codes. We currently have about 36 states that are currently paying the COCM codes and 14 that are not paying. One of the downsides is that there's a lot of heterogeneity in how much these Medicaid plans are actually paying, the actual dollar value that they're reimbursing. And so in some states, as we think about trying to increase collaborative care, particularly in heavily Medicaid populations of primary care, it can be a challenge. And that's a large part of ACAP and APA's advocacy work, is really to work with those states and the state insurance commissioners to make sure that we are paying collaborative care at a rate that is acceptable and commensurate with what CMS and the commercial payers are paying. We know that primary care docs hate to do things differently for different patients, right? They want to be able to say, we have a COCM program here, and regardless of if our patient is commercially insured, if they have Medicare, or if they have Medicaid, they should be able to access the same clinical program. And I think that's a big part of the push that is driving us to expand these codes and provide some equity in payment across them.
Thanks, Tristan. It really is reassuring to know that insurers are supporting collaborative care models and the collaborative care code payment. And I know we have to work some of the bugs out in some of the states as far as amounts being paid. But some of that can be compensated for by how many kids are followed on a registry. We always want to follow them enough that they get good care. But where the pay is lower, people may have to start with having a few more people on the registry in order to fund their infrastructure, but it's very possible.
I think it's a great point. And, I think before any practice jumps into the collaborative care program, they should start with developing a pro forma that really looks at how many patients am I going to need to have in this program to have it pay for itself. And so those who are working with implementation groups like the AIM Center or with Meadows, they will help you create a financial model to understand how many patients do I need to flow through here of what insurance mix in order to make this program financially solvent.
Yeah. Thanks, Tristan. I have a few questions for you. What are some ways you see for child psychiatrists to advocate with payers to set appropriate rates of reimbursement and to cover these collaborative services?
Yeah, so I think for the most part, as we mentioned, the commercial rates are being codes are being covered under commercial plans pretty consistently. I think in states, particularly Medicaid states, where the codes are underfunded or where the codes are not covered at all, there's a great opportunity to do some advocacy work there to ensure that Medicaid does pay the codes. And, we talk about commercial payers like the one I work for, or even, state Medicaid plans as being these really, kind of aloof and distant entities, which an individual provider may not have any access to. And that's actually not true. Most of us who work in insurance plans have the ability to call our plan liaison and talk about this. Alternative payment models are developed this way all the time. And so, don't be afraid to reach out to the insurance plan. Don't be afraid to reach out to your state and say, hey, this is important for my patients. We need to do better, and to really advocate for yourself, because those calls and those outreaches do matter. They do make a difference.
Thanks. And we're really happy to have you, Tristan, on our Healthcare Access and Economics Committee at the Academy, because you can speak both as a practicing child psychiatrist and also as a medical director at an insurance company. And that's been very invaluable to us. How do you perceive wider networks of care beyond simply collaboration between a child psychiatrist and a primary care practice? As we showed in that earlier diagram, outreach into the community in some way. How would the insurers be involved in things like that?
Yeah, so payers will oftentimes be very interested in new ways of providing care, particularly if they, double click on some of those key interests that I mentioned earlier. They use measurement-based care, that the value can be well described. Now, what an alternative payment model is basically kind of a customized arrangement, a customized code that can be developed to describe your specific work that you're doing with an insurance company. So that might look like a bundled payment, right? So we might pay for an episode of care as opposed to individual sessions of care. That might look like sharing in some of the savings that a plan might develop for a particular type of care. And those can all be developed with an individual plan. There is a challenge, however, though, that when these alternative payment models are oftentimes between a specific plan and a specific provider. And so unless you're going to develop the same alternative payment model with each of the plans that you work with as a provider, as a clinician, then sometimes it's hard to get alignment there. Plans are prohibited from kind of working together to come up with alternative payment models that look exactly the same, because it starts to look like collusion, or it starts to look like they're working together to benefit commercial interests. So in general, we have seen a lot of advocacy groups that have brought together convenings to help establish some general principles. What would some alternative payment models look like that many plans could be satisfied with and happy with? And those have been helpful in terms of advancing some of the alternative payment models and some of the ways in which we might improve collaborative care going forward.
Thanks. It's very helpful for us. And how about to finish, are there ways that an insurer can help support startup? Are there ways that that can get things going? Because sometimes there's some upfront support that's needed to get infrastructure set before we can start billing the codes.
Yeah, so many of the payers are providing some startup support for primary care practices that want to implement collaborative care. What's interesting is that, collaborative care, because it's billed by the primary care doc, is actually billed to the medical benefit. So those of us who are used to working with mental health carve-outs, such as, Optum Behavioral Health or Magellan or a lot of the traditional carve-outs, the collaborative care codes don't actually come out of the behavioral side. They come out of the core insurance side, right? The medical benefit, because they're billed by the PCP. And so oftentimes those groups are the ones that are supporting startup costs associated with collaborative care. So where I work, United Healthcare has supported with it through a number of grants, the startup of collaborative care practices in primary care. We don't have to look, if we look to Michigan and what Bill Beecroft, a psychiatrist, has done there. Blue Cross of Michigan has supported the implementation of collaborative care in, I think hundreds, dozens at least, of practices across the state. And we see many payers doing this. They all do it in a slightly different way, but insurers recognize that it can be a heavy lift to get collaborative care going, but they see the long-term value in it, and so they're willing to help support. So this is a great opportunity that if you're looking for some of that support, to reach out to some of the bigger plans that you work with and say, hey, how can you help?
Thanks, Tristan, for the reassurance. I hope that will be reassuring to many of the people listening to this presentation who really want to get started and don't want to have to wait a long time to do it. And finally, Erin, Chudzik Pryor will introduce herself, and she's going to present 3 slides, and then I'm going to ask her some questions as well. Erin, welcome.
Thank you. I'm Erin Chudzik Pryor. I am a physician assistant at Delaware Pediatrics, and I am part of the collaborative care model with Dr. Bohr through Delaware Pediatrics, and we are entering our 3rd year in a co-CM model, but we've been involved with the Delaware Child Psychiatric Access Program for almost 5 years now. My slides are just a bit of an overview of our 2023 data from the registry to give you kind of an idea of how many patients we followed and what their outcomes may have been. As you can see, 73% of patients either remained in the practice at that level of care, not needing to advance to seeing a psychiatric nurse practitioner or psychiatrist directly. And the 11% where it says moved for other reasons, moved or insurance, that was an insurance change, not insurance change related to like coverage for co-CM. So our practice no longer took their insurance, so they moved to a different state and moved on. The patient testimonials, I think, is probably the biggest telling point of how impactful a collaborative care model can be. We have not only improved access to care, but we have delivered care in a medical home setting with tremendous outcomes for both our patients and their families. Without that kind of feedback, I don't know that we would have been as successful as we have been in advocating for payment from insurers as well. But as you can see, like life-changing results for patients and families. Over time, we've kind of changed the trajectory of how we're delivering care and improving our own internal workflows and our work systems. Our providers, through the use of the program, through continued education, have become much more confident in their own ability to diagnose and manage patients with different mental health diagnoses. We've continued to cultivate more relationships with our community partners. We're improving things like our workflows, medication compliance, follow-up appointments, missed appointments, and just in general better outcomes. And our communication and follow-up is now done by our collaborative care team instead of our individual providers.
Thank you, Erin. And can you give us your perspective on your role as a behavioral health care manager in this primary care practice, creating and following a registry or a list of youth with a child and adolescent psychiatrist?
Yeah, so my job is boots on the ground to put all of these flow charts and work patterns of how each of the partners in play, contribute to this model. If I walked into your office and said, I want to improve access for care for your patients with mental health diagnoses, there's not anyone on this team or any practice in the world who would tell you no. Acknowledging that you have less time with your patients for visits, you have an increasing number of mental health related visits coming into the office, and being able to say to providers, like, we're going to put a system in place that allows you to improve that access, that allows you to get that evidence-based outcome, all while removing some of the burden from your plate, and to do it in a model that is more organized and improves communication with the providers and with the families, you're 100% going to sign up. And that's exactly what developing the registry did for us. It took work systems that maybe were fragmented or intended, but not always followed through on, into a systematic approach that really allows us to improve our outcomes and to improve the communication both between myself as the care manager and the providers, as well as the families and patients.
And could you say a little bit more about how setting up the workflow and especially the billing workflow, how that affected the practice? Because I know that'll be a question that both the child psychiatrists and pediatricians will be asking.
Yeah. So we established workflows where in the beginning, the patients were being referred onto the registry by the primary care provider they were seeing. So someone who maybe had a positive PHQ score and signs of depression, the provider would reach out and say, hey, I think this, kid should be followed on the registry. Over the past 3 years, we've changed how we kind of initiate that. That flow still happens. But now as we are kind of onboarding or doing intakes for new behavioral health concerns, those patients are automatically getting added to the registry, which has created more of a balance of not all of the children on the registry are maybe very complex, both in their medication and diagnoses, but they might be new starts of medication and need closer monitoring for compliance and side effects and consistency with appointments. From a billing standpoint, we use the registry to capture the time and how much interaction we might have with the families, and then turning that into integrated systems with our EHR to be able to bill out that time. So workflow things that maybe were intended are done, but not in a way that was organized, meant that tasks were happening that could have been billed under a collaborative care model that were not. So while we have increased the amount of outreach we're doing in between visits, we also have been able to recapture times where we would not have billed for the same services. So we've improved existing flow and created new workflow patterns to really capture time to be sure that we can get paid for the work we're doing.
Thanks, Erin. And just a quick observation, being a PA in your practice, you're also able to do well visits, you're able to do E&M visits, and you're able to write prescriptions. I know you can't use that same time. We can't double bill. But I know that there are kids that need that extra service, and you're able to do that. And that also helps support your practice, I believe. So, the collaborative care model and your traditional model are working side by side, not just with your practitioners, but with you as a behavioral health care manager.
Absolutely. Absolutely. We've been really able to capitalize on that. So when I see a patient for an anxiety follow-up, or whether it's my own patient or one of my partners, I can capture that time and then feed that information back into the EHR to the correct provider if they're not my patient. Because of I see my own patients and do medication management and have that workflow kind of already established with the provider who I may be coordinating with.
Thanks. And what have you found to be the best ways to communicate with those patients you're following on the registry? Because I know you have to check in with them frequently, more frequently than what would be a typical follow-up visit for a pediatrician.
Yeah.
And I know you're doing screenings and measures as you go and following parameters that have been set for that particular patient. So how do you communicate back and forth with these families?
Yeah, so telemedicine has been wonderful. We utilize it a lot, not just for appointments, but for check-ins in between. But the game changer for us has been texting, both from a teen model and from, contact with parents, sometimes both. Using a HIPAA secure texting modality has really been just amazing. We've eliminated a lot of phone tag. Parents sometimes will text me like, I know it's the middle of the night, but I know you're going to have this in the morning, and then can update, or if something is happening at school and there's something more emergent or urgent, they're able to send those messages. It is also tracked into the EHR so that in the event that someone was on vacation and that texting message didn't come through, it's still monitored by triage if it's left hanging, so it would be addressed. But that really has been, parents love it, teens love it. We're able to do the things we would do in telemedicine in a really quick way. We've established kind of scripts, so to speak, of some of the things we want to send out, like I need an update on this and tell me these side effects, and are able to automate some of the things almost, which has really been great for workflow.
And your practice has been involved with our Child Psychiatry Access Program for encounters with a child psychiatrist and a Child Psychiatry Access Program. You've also benefited from trainings and our learning management system and other resources. How has this service prepared Delaware Pediatrics for Pete's COSIEM and the participation of the members of your practice in it?
Yeah, so our initial kind of start was that we recognized the increasing number of mental health concerns and visits coming into the office. And we have a mix of providers. Some are very confident in their mental health diagnosis and treatment. Some are very passionate about it, and some don't want any real parts of it. But, you know, it affects every aspect of pediatrics. So kind of coming together and utilizing first the Delaware Child Psychiatry Access Program gave us the ability to utilize the hotline, to take advantage of some of the educational opportunities, to really kind of improve our own knowledge base. Through the COSIEM, we have seen that has just exponentially increased. We have been able to use our 2023 and early 2024 data to go to the insurance commissioner for the state of Delaware to advocate. And we now can say that in Delaware, the Medicaid MCO plans are all covering the COSIEM codes, where for a period of time they stopped. And that is solely based on our outcomes, our patient testimonials. We've also been able to utilize the registry to really track a lot of trends and to track outcomes that are more relevant. So looking at things not just like a PHQ and GAD score, which absolutely have their place, but looking at things like missed work time, ER visits, opportunities for self-harm, thoughts of self-harm, and tracking comorbidities. We've seen that obesity has been a common trend, the most common comorbidity for all of the kids we're following across the registry. And our practice has taken steps through a secondary grant, to really start to address obesity management with a health coaching model in the context of mental health care.
Thanks, Erin. So you're really delivering true collaborative care, and you're delivering care that covers physical as well as emotional issues. And I just think it's wonderful. Plus, you're having fun, aren't you?
We are having a lot of fun. And patients really, you know, the access is a huge thing in the state of Delaware. The number of providers is ever shrinking. And sometimes that is access from a financial standpoint, from an insurance coverage standpoint. Sometimes that is access by proximity. Our lower counties, their population is ever increasing, but their number of providers in general is sparse. And the number of available psychiatric nurse practitioners and child psychiatrists is an ever shrinking number. And a program like this equalizes the access opportunity, as well as giving high quality care in a medical home setting. And you're right, not every patient who has ADHD necessarily needs to see and be managed by a child psychiatrist. You know, having everyone working at the top of their license and allowing kids who do need to climb the ladder up to a higher level of care also creates the opportunity for the consulting psychiatrists to see more patients through this model, and to open the access points for those who really critically need more consistent one-to-one treatment with the child psychiatrist.
Thanks so much, Erin. And I'd just like to say, as our team members come back, all our presenters today, I'd like to thank each of you for being here, for letting me interview you, for interviewing me. And I hope that together we've given some inspiration and encouragement from our different perspectives for people, our child psychiatrists at all levels of practice, and our trainees at all levels of practice to watch and to feel inspired to go ahead with these models. And we will have a future scheduled sometime in the future, an open question and answer session with the panel you see here, so that you may be able to get further answers to your questions that did not come up during this program. Thank you very much.